All right. Anna, perfect. Thank you so much.
hmm
All right. So welcome everyone. Thank you so much for making time, just confirming you can all hear me on this. Great. Thank you, Mary Alice. Thank you, Anna. Um, Thank you so much for making time to join for today's session. This is always a really exciting time of the year as our master students present on the work they've been doing throughout the past few months. And in today's session, we will specifically be focused on the presentations related to four master's essays. We're going to get started with Anna Breen. Anna Breen's area of interest is women's sexual and reproductive health. And sorry, I'm just seeing something in the chat real quick that a few folks are late due to clicking the Teams link. So hopefully they're joining and getting situated in this room. Sorry about that, Anna. Okay, so back to Anna. Anna's our first presenter of the day. Anna's area of interest is women's sexual and reproductive health. Anna has a bachelor's of science degree from Oregon State University with a major in bioresource research. And today I'm very excited because I had the pleasure of working with Anna on her master's presentation. And she will be presenting on her master's essay, Kind of Makes Me Want to Have Kids So I Can Do It Right, a qualitative study of transgender and gender diverse adolescents' fertility counseling experiences in Australia. Before I hand it over to Anna to get started, just a quick reminder that folks will have 10 minutes to present, and then we'll save 5 minutes for Q&A. So Anna, go ahead and take it away.
Cool. Thank you, Celia. Welcome, everyone. I'm very excited to talk to y'all about my field placement and my master's essay. And so here we go. Um, so just to kind of outline what we will be talking about today, I'm going to talk a little bit about background of this topic. I will go over methods of the study, some themes that emerged from our data, and then implications of those themes, and then wrapping up with acknowledgments and Q&A. So just a little bit of background. There's kind of like three driving forces, I guess, of why we wanted to do this study. The first being that gender-affirming medical treatment reduces fertility. So that can be gender-affirming hormones, gender-affirming surgeries, puberty blockers, which delay puberty. And because they reduce fertility, WPATH, or the World Professional Association for Trans Health, recommends discussing fertility preservation options with patients when they initiate care. But that guidance doesn't specify when or how to offer fertility counseling to trans youth. They focus a lot on fertility preservation and not non-biological methods of parenting or parenting desired conversations in general. And so that alongside there being kind of a lack of qualitative evidence of trans youth fertility counseling experiences in the literature kind of all culminated in why we wanted to conduct this study. So, with that in mind, our aims were to primarily explore the fertility counseling experiences of trans youth in Australia, as well as understand broader perspectives on reproduction and parenthood, and kind of use these findings to inform future clinical practice. And so the methods we used for this study were we recruited from a single tertiary referral-based hospital in Melbourne. That's the Royal Children's Hospital Gender Service in Victoria, which primarily services most of Victoria for pediatric trans care. And participants were between the ages of 9 and 18. They were current patients at the gender service. They had been on gender affirming hormones or puberty blockers for at least 3 months, and all of our participants had undergone fertility counseling. It's very recommended when they start treatment that they undergo fertility counseling, but it's not technically required of patients. We conducted individual semi-structured interviews where participants were interviewed for 20 to 30 minutes over the phone. And then we looked at that data, kind of developed a code book alongside it, and grouped those codes into themes. So this was an exploratory approach where we didn't really go into it with a hypothesis. We just wanted to see what participants had to say and develop themes from that. So the resulting themes were prioritization of gender-affirming medical treatment, dysphoria, parenting desires and influences, and trust and information seeking. And I'm just going to show y'all a quote that kind of encapsulates or is relevant to each theme while I also talk about those themes. So, for prioritization of gender affirming medical treatment, there were really two kind of broader areas in this theme. The first being hesitancy to delay care in pursuing fertility preservation, in pursuing additional fertility counseling sessions. Participants were very eager to start their treatment and very certain about starting their treatment, where maybe they were more uncertain about their parenting desires, as well as participants like Amanda here who kind of decided, oh, I will maybe pursue fertility preservation or fertility options later. But there were limitations to pauses to gender affirming medical treatment in order to do so. Here she says 2 months was how long she would be willing to go off of her estrogen in order to achieve fertility. And so dysphoria was also a really prevalent topic in these interviews where participants either kind of experienced some dysphoria during the fertility counseling process due to just talking about reproductive parts that was distressing, as well as some anticipated that fertility preservation would cause dysphoria, which motivated their decision making, where some participants opted not to do fertility preservation because they were worried about the dysphoria that might be involved, as well as some participants like Alexi, who did opt to do fertility preservation, experienced dysphoria in doing so. Here, Alexi describes how she kind of experienced this distressing heteronormativity at the fertility clinic that was very like cisgender, heterosexual crowd oriented, and how that kind of evoked some dysphoria for her. And then the next theme was, parenting desires and influences, where participants really did talk about how they wanted to be parents. The majority of our participants expressed having a desire to be parents. And there was a lot of conversation around adoption and non-biological methods of parenting, where a lot of participants planned on pursuing adoption. And whether that be adoption as a means of kind of avoiding the distressing aspects of reproduction or fertility preservation, whether that be like Bobby here, adoption being the backup plan. If, he changes his mind later, he could always adopt. As well as some participants were just like, I think adoption's really cool, and I would just love to adopt because I think it sounds neat. Whatever the reason, participants brought up adoption quite a lot and non-biological methods of parenting. So that was a really, really prevalent idea. And then finally, participants talked quite a lot about where they were sourcing information about their fertility and the role of trust in that information seeking process. Something that I really loved about these interviews was participants quite often talked about really liking their clinicians and their care team, feeling that their care team empowered them, that their care team helped them make the decision that was best for them. Riki here describes his doctor as more than just a doctor, but a friend. And so trust was really important. Participants also talked about family members and friends as being trustworthy sources of information. And really importantly, and I don't know, heavy on my mind as analyzing this data was without prompting, we didn't really ask about online resources or digital resources in the interview guide, and yet participants often brought up going to Facebook, going to YouTube, going to Reddit, using online sources to find information and how they trusted those sources. And one participant here suggested having maybe the clinic or having it be a part of the fertility counseling sessions, that there is a digital resource like a video or website for participants to go back to later, and kind of highlights how fertility counseling isn't just like or shouldn't be just one session and then you're done and you move on, but that it's this continuous process that you come back to and you think about more later. And having resources that are digital, that are outside of the clinic is a great way to empower participants to do that. So there are a lot of implications of all these themes. I chose to talk about three. And the three that really stick out to me and I feel like really stick out in these findings. The first being to upskill care teams, whether that's implementing a social worker to talk about adoption and the feasibility of adoption with participants into the care team, or increasing clinician knowledge about the adoption process for those who do fertility counseling, whatever that looks like. Participants really expressed wanting information and being invested in the idea of non-biological parenting methods. And current guidelines are very focused on fertility preservation. Expanding online resources, like Ainsley suggested, as well as co-design with trans youth. I think a lot of research kind of puts like participants at the end of the study, or have someone review the paper at the end of the research, or, but I think that including trans youth really early in research as co-investigators to design these studies and to design new guidelines is really important, because ultimately trans youth are the experts on this topic, and they should be at the table when we're developing these guidelines and having these conversations. And finally, I just want to acknowledge my lovely supervisors, the gender service, the trans young people who participate in this study. And I also want to thank all of my trans loved ones who have informed who I am as a person, which ultimately informed the study as well. So thank you to everybody. And I will now take questions.
Wonderful job, Anna. Great way to get started with the session. So thank you so much. You have a plethora of claps and hearts in the chat here, or in the Zoom world. All right, well, we'll get started with some questions. I always like to prioritize fellow student questions. If anybody has questions for Anna, you can go ahead and either raise your hand or just come off mute, and we can go ahead and get started with students.
I'm curious, did any of these findings surprise you, or is this what you sort of expected to see from the data?
Interesting. Yeah, I think the literature shows that a lot of this population cares a lot about adoption, and dysphoria plays a role in all these things. So none of those findings were surprising. I think the one that was the most surprising was a lot of these participants wanted to be parents, and it's mixed. The evidence is not high quality per se, but I don't know. There's kind of a impression, I guess, that I get, and that is in the literature a little bit, that trans kids don't want to be parents, and they don't have as much of a fertility desire as cis kids, which was very much not what we found. And I think that maybe that just means something greater. Maybe it's just that's kind of a limitation of this study, was that it was a small group of people at one clinic who, definitely had very supportive parents who were yeah, you can do this research project. And, also they're ones who opted to do fertility counseling. It's not like we also interviewed kids who didn't do fertility counseling and why they opted not to. So, obviously there's a lot of limitations there, but I think that was something that surprised me and was really interesting to see, was a lot of participants were yeah, I want to be a parent, and they talked about it in quite a lot of detail.
Thanks, Anna. Thanks for that great question, Isabella. While others potentially raise some questions, I have a question for you, Anna, which is about kind of to your point about this being not potentially what you expected based on the literature. What do you think that kind of means for next steps of this work, and kind of how the field can integrate those perspectives, and the fact that fertility counseling and acknowledging, longer term or dynamic fertility intentions of that population is important as part of the process.
Yeah, I think kind of like I'd mentioned, I think next steps are co-designing with this population. And, you know, something that I really appreciate about this research team and this work that I did was that there was a trans young person who advised with designing the interview guide, and then also they're reviewing the paper, and that's awesome. I think also that person like uh should also be there for a higher order of study design. And I also think that just generally I would really like to see WPATH release more specifics on their recommendations for fertility counseling, because they're pretty much like tell people that fertility counseling is an option if they want to do it. Here's all the fertility preservation technology you can tell them exists. And it doesn't really give guidelines on how do you go through that decision-making process with patients. How do you do it with like kids? Our youngest participant was 11. So it's like talking to an 11-year-old about, what fertility preservation and also parenting and all of those things is going to take a different approach. So, yeah, I think those are kind of my thoughts on that.
Great. Thank you so much. You raise a lot of really interesting points, especially about that, about the need for that counseling in the context of fertility preservation and other aspects of that decision-making process. So thank you so much, Anna, for the time being. We will direct more questions to Anna into the chat, and we'll move on to our second presenter. But wonderful work, Anna, and great way to get us started.
Thank you.
Thank you. All right, Arfisha, you can go ahead and share your slides while I introduce you. Our second presenter is Arfisha Muwahidah. Her area of interest is child and adolescent health, and she came to us with a bachelor's degree from Bandung Health Polytechnic University at the Ministry of Health, with a major in nutrition and dietetics. And her master's essay title is the USDA Afterschool Supper Program in Maryland, a mixed method study of implementation during the 2018 to 2023 school years. So I'll hand it over to you, Arfisha. Thank you. You are still muted. There you go.
So much, Dr. Karp. Good afternoon, everyone. Thank you for being here. My name is Arfisha Muwahidah. Today, I'll be presenting my master's essay titled the USDA Afterschool Supper Program in Maryland. This is a mixed method study of implementation during the 2018 to 2023 school years. So this research was conducted under the supervision of Dr. Erin Hager in collaboration with the Strong Research Group. Let me start with the background and context. In 2023, approximately 7.2 million children in the US lived in the food insecure households. Here in Maryland specifically, about 9.5% of households experience food insecurity. So as we know, food insecurity is the lack of consistent access to sufficient, safe, and nutritious food for healthy living. To address this, the CACFP established the At-Risk After-School Meals Program, providing meals after school alongside the enrichment activities. However, the program comes with significant structural constraints, such as sites must meet 50% free and reduced price meal eligibility, meals must be served in congregate setting, and also the program depends heavily on after-school program, transportation, and also staffing. And in many cases, sites offer snacks instead of the full suppers. So I want to highlight what actually motivated this research. Starting in March 2020, USDA implemented nationwide waivers in response to COVID-19. These waivers removed area eligibility requirements, allowed grab and go, and permitted virtual enrichment activities. And as you can see here, the impact on Maryland was significant, as the average daily participation surged a 435% increase from 2019 to 2021. Program sites expanded from roughly 300 to over 750 locations. But then, when the waivers expired in 2022, participation fell sharply to just 12,000 meals per day, dropping below pre-pandemic levels. And Breen, Maryland ranked among the top 5 states for the highest program dropout rates in 2022. So the questions were why and how did participation change? This study examines how the supper program was implemented in Maryland from 2018 to 2023, covering the pre-pandemic, COVID waiver, and post-waiver periods. We use an explanatory sequential mix method design with two specific aims. Aim one was quantitative, to analyze administrative data from the Maryland State Department of Education to identify district-level participation trend and patterns. Aim two was qualitative, to conduct semi-structured interviews with state officials, district food service directors, and local program agencies. These interviews were analyzed using iterative thematic analysis with a deductive codebook encoded in MaxQDA. And these two components, when then integrated, the qualitative findings were used to explain the quantitative patterns, and results were mapped onto ERIC, or expert recommendations for implementation change, to help translate the findings into actionable recommendations. For the result, starting with the quantitative findings, across the study period, we identified 5 distinct participation patterns based on how each LEA's participations change over time. So the pattern 1 was 1 LEA that never participated at any point. Pattern 2 was 9 LEAs that had pre-pandemic service, paused or decreased during the pandemic, and then resume or increase post-waiver. Pattern 3 was the largest group. There were 12 LEAs that had pre-pandemic service, surged during the pandemic waiver period, and then dropped sharply or stopped entirely after the waivers expired. And then pattern 4 was 1 LEA that started during pandemic and maintained stable participations. And pattern 5 was 1 LEA that maintained stable participation throughout all the 3 periods. But among these patterns, we only have the interview data for pattern 2, 3, and 5. Two key takeaways here are first, 52% of LEA experienced increase during the waiver period, followed by sharp declines, suggesting that pandemic era gains were not sustained after waiver expirations. And the second one, only 1 LEA maintained stable participations across all periods, highlighting that rarity of sustained implementation over time. Then for the qualitative findings, we start with the pre-pandemic period. Participation was already limited by a core structural constraints, as the program requires an after-school program that is open to all students. If students couldn't stay after school, they simply couldn't also access the meal. And also the transportation and staffing are barriers, with late hour shifting being difficult to fill. Some districts also try to work around this, for example, scheduling meals within an hour after the last bell to catch the students. But as long as access was tight to after-school program attendance, the program reach was still limited. During the pandemic waiver period, things changed significantly, but still uniformly. For district in pattern 3 and 5, increase or maintain participations, the key was policy flexibility, such as non-congregate and grab-and-go service. Many districts also bundled meals, picking up every breakfast or lunch together with the supper, and also expanded eligibility allowed new communities to participate, and strong leadership can really drive this implementation. But for district in pattern 2, participation actually declined. When schools closed, there was no after-school setting and therefore no setting to provide meals. Resources were concentrated on breakfast and lunch, and staffing safety concerns prevented a return to after-school programming. And the waivers ended, participations declined sharply. In this period, for pattern 3 districts, the return to congregate meals requirement reinstated barriers, so families with transportation and scheduling constraints couldn't overcome it. Cuts to after-school programs and transportation also reduced the program sites, and staffing shortage and supply chain issues still persist in this period. For pattern 2 and 5, district gradually rebuilt through outreach to principals and athletic directors, but still slow progress. Those with retained infrastructure were better positioned to sustain programs, but compliance pressure and audit risk constrained the flexibility they needed. in broader context. So our first discussion is supper depends on after-school infrastructure and policy flexibility. The coverage was consistently limited by transportation, staffing, and enrichment activities, which all factors are largely outside the nutrition program's control. The COVID-19 waivers lifted these constraints, but when the waiver expired, structural barriers returned. When participation fell below even pre-pandemic levels, it wasn't about reduced need in communities since the food insecurity is actually still persists. Our second discussion is district varied in response based on local capacity. Even under the exact same federal policy, Maryland LEAs responded very differently, which reflected what each district had to work with in terms of staffing, infrastructure, and partnership, and also the leadership. And participation numbers alone cannot capture the full picture of these implementations. And the third discussion is leadership engagement with a cross-cutting facilitator. School and district leaders shared program outcomes independently on structural conditions. We find the superintendents who showed up at a distribution sites every single day drove exceptional performance during the waiver period. But what the level of leadership pulled back after the waivers ended, the programs become vulnerable again. But the real takeaway is the leadership engagement needs to be built into the system structurally through principal onboarding, professional development, and also district level accountability. Based on these findings, improving the supper program requires action across multiple levels. All of these recommendations are aligned with ERIC implementation strategies, including obtaining formal commitments, building coalitions, altering incentive structures, and conducting educational meetings with local opinion leaders. On policy side, making non-congregate service and parent pickup permanent, and also lowering the 50% area eligibility threshold will directly address the structural constraints or for our study or for this study on this district capacity, staff training, higher wages, and state level learning collaboratives for nutrition directors could also strengthen implementation across the board. On after school infrastructure side, strengthening partnership and coordination to expand after school program and transportation is also essential. And from the school leadership side, professional development for principal on child nutrition programs could make a meaningful difference here. For the strength and limitation on the strength side, this study used a mixed method design combining longitudinal administrative data from 2018 to 2023, captured the full arc of pre, during, and post-pandemic implementations, combined with qualitative insight from implementers across the multiple districts, and the use of ERIC strategies strengthened both the interpretive depth and the practical relevance on our conclusions. On the limitation side, qualitative data were only available for 3 of the 5 participation patterns, and also using the small and self-selective sample. And because this study focused on Maryland, findings may not be fully generalizable to other state policy environments. All right, before I close, I want to take a moment to thank everyone who made this work possible, Dr. Haggers as my readers, and also my field placement preceptor, Nan and Jenny as the co-author, the Strong Research Group, Dr. Karp, my academic advisor, also Aaron Michelle as my GSA NF supervisor, also deeply grateful to my parents, families, and friends. Thank you so much. I'm happy to have the questions.
Wonderful job, Arfisha. Thank you so much. This is very, very impressive work. I don't know if you want to keep, well, you can keep the slides up if somebody asks questions specific to some of the data you presented. But it was really impressive and exciting to see the work that you're doing with Dr. Hager's team. I will open the floor to see if any students have specific questions for you. And if folks don't come on immediately, I have some questions as well. So you have one question in the chat. Christy, did you want to come off mute, or would you like me to read your question? All right, I'm gonna just read your question for the sake of time. So Christy says, a great presentation and good work on your findings. I'd love to hear what you found the most interesting of your findings in the study. So what was the most interesting finding for you, Arfisha?
All right, thank you. Thank you so much for the questions, Christy. To craft these findings of this study, I also refer to some report that has been released by Food and Research Action Center, or FRAC, because they usually yearly release the report about supper program, and they actually identified the findings about how this program meets these challenges, such as how this program attached with the after school program, so it's not independently program who can run different with the breakfast and lunch program. So as expected, the transportation, the attachment with the after school program, and also the staffing issue was actually the finding that has been come and discussed in the FRAC report. But the most interesting that I found here, based on our interview result, is about the leadership engagement, because it hasn't been discussed in the FRAC report, but when the LEA, or local academic agencies in county level, mention about how this leader have such an important role to encourage the program among the school environment. And also I find the transition, whether the leadership needs to be substituted to another person, and then the new leaders hasn't been decided, haven't really decided about this program running in the school. So this is why the leader is very important in encouraging the program. And also when the school leader approach the parents to support this program for their children, is actually also have significant impact, rather than the nutrition officer who approach the parents to support this program. So this is a quite important for the practitioner, or to the policymaker, to also involve the leaders at school level, especially if they haven't really aware with the nutrition program to be exposed by this kind of program.
Great, thank you, Arfisha. And I can see how that would play a really important role in terms of trust building within schools, and bridging those connections between programs that might be a little bit operating separately from other dimensions of how the school is run. So I can see that being a really important finding. I think we have time for one other question. You have a question from Madison in the chat. And Madison writes, did the reimbursement structure for the LEAs stay the same throughout the study period? And this is in terms of the money provided per participant or similar?
Yeah, thank you, Madison, for the questions. Based on what my understanding, during the COVID waiver, the reimbursement is actually still the same, which means that this supper program, since this is under CACFP program, not under the National School Lunch Program, it has kind of different reimbursement process. But during the COVID waiver, it still has the same process or budget for the reimbursement, but the different things is the area eligibility that made it different, because when it is not in the COVID or pandemic period, the sites that will be eligible for the supper program needs to have minimum 50% of the students that has free or reduced price of the meal eligibility. But since the COVID waiver, so this program becoming universal, they didn't really apply the area eligibility, the 50% regulations to the sites. And this is also help the students or children who live in the rural area, who actually, let's say they are living in the poor economy level, but it's not really compiled in one area, then the area is actually not fulfilling the 50% of free or reduced price of the school meal program. But since the COVID waiver, they still also the beneficiaries of this program, since this is all universal targeting.
Thank you. Thank you so much. And others, please feel free to add additional questions to the chat, and Arfisha, you can respond in the chat throughout the remainder of the session. Thank you so much. That was a wonderful presentation. All right, we will move on to our third presenter. Thank you. Our third presenter today, thank you. Our third presenter today is Demi Bajela. Demi is a student focused in the area of interest for women's sexual and reproductive health. And Demi joined us at Johns Hopkins after obtaining a Bachelor of Arts degree from Washington University in St. Louis with majors in anthropology, global health environment, and Spanish. And today, Demi will be presenting on her master's essay entitled Individual Level Determinants of Engagements with SurrEndo, Grant Proposal for a Serious Game Intervention for Endometriosis Stigma Among Black and Latinx Adolescents and Young Adults. Feel free to take it away, Demi.
All right, thank you for that introduction, Dr. Karp. So I'll just go ahead and jump right in. During this presentation, I'll walk through the context of this research proposal, current gaps in existing literature, and the study approach. Lastly, I'll walk through the implications of this research. So I'll start by level setting and providing some context about this research. So starting off, endometriosis is a complex hormone and chronic inflammatory reproductive condition, and it is characterized by growth of cells that are similar to those found typically in the uterus lining outside of the uterus. And these growths can cause lesions and cysts that have been found in nearly every organ of the body. Some individuals may experience symptoms like severe pelvic pain, painful periods, fatigue, GI and urinary dysfunction, as well as infertility. However, these symptoms vary across people, and that makes this condition difficult to diagnose. So the origin of endometriosis is currently unknown. It is estimated that 1 in 10 women and individuals assigned female at birth are affected by endometriosis. However, it is believed that this may be an underestimate due to the heterogeneity of symptoms and delays in diagnosis. And right now in the US, it takes about an average of 8 to 10 years from symptom onset for individuals to be diagnosed with endometriosis. Diagnosis is typically confirmed through surgery, but even with the diagnosis, individuals are often limited in treatment options because there's no cure for endometriosis. And when we consider the impacts of endometriosis, we see that previous research has shown that it's associated with increased social isolation, decreased quality of life, increased symptoms of depression and anxiety, and a worldwide estimate of $80 billion being spent on endometriosis-related care each year. So when we look at existing literature, we can see that much of the research on the impacts of endometriosis has been primarily focused on adult populations, but we know that endometriosis symptoms often begin in adolescence, yet there are relatively few studies that have actually looked at endometriosis among adolescents and young adults. And in addition to this, we also see that because endometriosis has been historically perceived as a condition that mainly affects cisgendered, non-Hispanic white women, often Black, Latinx, Indigenous, Asian, and non-cisgendered populations remain underrepresented in the literature. Lastly, there's also limited published interventions aimed at addressing factors that contribute to diagnostic delays. And these factors are things like menstrual health stigma, symptom normalization, and low awareness of endometriosis in patient and clinician populations. Finally, few studies have actually leveraged digital tools such as mobile apps or other digital health platforms to really deliver accessible interventions for individuals with endometriosis symptoms. So this is where SurrEndo comes in to address some of the gaps that I just discussed. SurrEndo is a mixed methods pre and post intervention study that is centered around a serious game design to improve endometriosis awareness, encourage symptom tracking, strengthen coping skills and self-efficacy, reduce stigma, and build social support for Black and Latinx adolescent and young adults aged 13 to 35 years. And I want to take a quick step back to explain what I mean by a serious gaming intervention. These are typically digital interventions that use game-based features to promote learning and behavior change while also being enjoyable for the end user. So for SurrEndo, the app shown here on the screen includes a storyline that takes participants through the journey of a main character as she's getting diagnosed with endometriosis, as well as it includes quizzes, mini games, journaling prompts, a symptom tracker, and educational pamphlets with links to additional resources. So while SurrEndo is evaluating participant outcomes, there's a need to really understand what is influencing whether participants actually engage with the intervention. We know from prior research that suggests that psychosocial factors can shape how adolescents and young adults navigate chronic conditions, how they seek care, and how they manage their symptoms. And those same factors may also influence whether they even engage with a self-directed digital health intervention like SurrEndo. And because the success and scalability of SurrEndo depends on meaningful engagement, really understanding and taking the time to understand the individual determinants is important for designing implementation strategies that can support the acceptability and equitable reach of the app. So building on that, this proposed study is guided by three specific aims. First, this study is looking to identify individual level determinants of engagement with SurrEndo using an integrated mixed methods approach that combines quantitative and qualitative data. Second, to categorize the determinants identified as implementation barriers or facilitators using theoretical frameworks. And third, to examine whether baseline psychosocial resources such as perceived social support and self-efficacy are associated with levels of engagement with SurrEndo. So this slide summarizes the hypothesized relationships guiding my specific aims. Based on prior research, I hypothesized that psychosocial factors will be positively associated with engagement with SurrEndo. Specifically, I'm hypothesizing that participants with higher perceived social support and also greater chronic pain self-efficacy may be more likely to spend time using the intervention and really engaging with the different components of the app. I also expect that engagement may vary across different psychosocial profiles, which may highlight within population differences in the intervention's reach. Overall, I'm hypothesizing that differences in engagement will suggest potential inequities in reach that can then help inform and help select adaptive implementation strategies. So this study is guided by three complementary frameworks. First, we have CompB model, which will help conceptualize engagement as a target behavior that is shaped by person's capability, opportunity, and motivation. While we also have the theoretical domains framework, which helps categorize specific barriers and facilitators to influencing engagement. And lastly, we have the CFER framework, which helps to situate these findings in an implementation context to support strategy selection for future intervention scale up. Together, these frameworks provide a theory-informed approach to understanding and improving engagement. So to address these aims, I'm proposing a secondary data analysis that is embedded within the larger SurrEndo study. The proposed study uses a convergent mixed methods design, which I will explain more in the upcoming slide. And the analytic sample includes Black and Latinx adolescents and young adults that are participating in SurrEndo. And lastly, the data source includes baseline survey data, in-depth interview data, and app engagement metrics. Okay, so for the analysis, quantitative and qualitative data will be analyzed in parallel and integrated to identify determinants of engagement with the SurrEndo app. Specifically, quantitative data will be analyzed using descriptive and regression analysis to identify candidate factors and examine whether psychosocial factors are associated with engagement, while qualitative data will be analyzed separately using a multi-stage deductive coding that is guided by TDF to identify participant-reported barriers and facilitators to engagement. And these findings will then be triangulated to identify a more comprehensive set of determinants influencing engagement. And when I'm speaking about integration, I'm meaning that the results from the quantitative and qualitative analysis will be compared to identify areas of convergence and areas of divergence. And then finally, the integrated determinants will then be mapped onto TDF domains and further interpreted through the COMP-B model to identify underlying behavioral mechanisms. So this proposed study has several potential contributions to ongoing research. First, it can help identify individual level factors that influence engagement with digital health interventions like SurrEndo that are specific to endometriosis. Second, it can help by combining empirical findings and behavioral and implementation frameworks. The results from the study can inform the selection of targeted strategies to improve uptake and sustained use of the SurrEndo app. And finally, by understanding who engages and also who may face barriers to engagement, that can help support a more equitable reach and participation in the intervention as the app is being refined and scaled up. So, like all research, this proposed study has both strengths and limitations. Some strengths include the use of a convergent mixed method design, which allows for a more comprehensive understanding of engagement, as well as the use of theory-informed frameworks to guide interpretation, and the fact that this work is equity-focused. At the same time, limitations include the use of a relatively smaller sample size, which may limit statistical power when we're measuring associations, as well as the use of proxy metrics that may not fully capture the quality of participants' interactions within the app. So I would just like to conclude by saying that, like we've seen time and time again with public health, engagement with health interventions is not an automatic guarantee once individuals have access. It is shaped by individual level factors that are also influenced by people's broader social and lived context. And by identifying barriers and facilitators, we can better design and support implementation of interventions in a way that supports meaningful engagement and in a way that is more equitable when we're trying to reach marginalized adolescents and young adults. And with that, I would just like to end by saying thank you to everyone who has supported me throughout this journey and open up the floor for any questions.
Thank you so much, Demi. Wonderful, wonderful job with your presentation. And thank you so much for providing that grounding and sharing kind of the framework through which you're thinking about these different aspects of the proposed work, which sounds really interesting. And I hope you do actually carry it forward into a grant proposal. Perhaps you've already done that. All right, I will open up the floor, as Demi said, for any specific questions related to Demi's master's essay and proposal. As we wait for questions to come in, Demi, I do have one question for you, which is about kind of this, the use of this serious game intervention. I think it's very cool, and especially, like you said, in terms of tailoring it to an adolescent population that might be very receptive to that kind of knowledge sharing and learning platform. I'm curious about other health outcomes or other reproductive health areas that have used this mechanism for delivering health related information, and maybe that was part of the background work that you did. So yeah, do you know of any others that have used kind of a similar serious game approach related to reproductive health topics specifically? And then I see you have another question in the chat.
That's a good question. When I was doing kind of the background research on this, I didn't see, there are some specifically looking at endometriosis. There are other digital health interventions. They're not specifically serious gaming digital health interventions, but other digital health interventions looking at symptom tracking. I found those. I haven't really seen many that one prioritize this adolescent and young adult population and also prioritize reproductive health topics. So that is something that I would have to go back and look at and really try to dig through and identify whether there are other studies that are looking at this. I know that they are, but I haven't seen many.
Great, thanks. Yeah, just might be an interesting area for the framing of this work. And I see a question from Isaac in the chat. Isaac says, great research on endometriosis, but why does the study focus on Black and Latinx adolescents and young adults rather than including all racial and ethnic groups affected by endometriosis stigma?
Yeah, thank you for that question, Isaac. So something that I didn't get to mention is that this is phase 2 of the app's development. So during phase 1, there were other ethnic groups that were included, but we found that participants primarily ended up being non-Hispanic white participants. So in order to really make sure that we're equitably including other racial and ethnic groups in the app's design, phase 2 was more targeted towards Black and Latinx populations, but there are also other non-Black and Latinx populations included in this sample. But this was just, phase 2 was emphasizing representation of those populations.
Great. Thank you so much, Demi. And for others who have questions, please feel free to direct them in the chat so we can just move along to our fourth presenter, but great work. Thank you so much. All right, our fourth, last but not least, our fourth presenter is Hanna George. Hanna George also has an area of interest in her master's program in women's sexual and reproductive health. She came to us at Hopkins after receiving a bachelor's degree from Virginia Commonwealth University with a major in interdisciplinary studies. And today, Hanna will be presenting on her master's essay, which is entitled Exploring Patient Portal Use Among Youth Living with HIV, a qualitative study of barriers, facilitators, and opportunities for engagement. Take it away, Hanna.
Thank you so much, Celia, for the introduction. So jumping right in, there are significant inequities in HIV burden among AYA, or otherwise known as adolescents and young adults. And these include individuals ages 13 to 24. And they represent 1 in 5 new HIV diagnoses in the US. And what we've seen in the research is that youth living with HIV, they face significant gaps in care and lower viral suppression rates. And this is primarily because a lot of youth are facing a transitional period where they're coming off of their parents' insurance plans or moving out, going on to college or getting a full-time job after they graduate. And so often this can disrupt their continuity of care. And these disparities are unfortunately not random. They're shaped by a range of structural, social, and individual level barriers that make it very difficult for youth to stay engaged in care. And so if we look at this diagram here on the right side, I've kind of summarized a few of the individual, community, and structural level barriers that impact whether they stay engaged in care. And so on the individual level, we see that low perception of risky sexual risk-taking behaviors, low sexual negotiation skills, which is basically the ability to communicate what are your needs and wants when you're having sex, as well as limited sexual health literacy. They can all work to limit the ability to get HIV care and also increase your chances of getting HIV. On the community level, the availability of HIV care and sexual education resources can also limit the ability for HIV diagnosed individuals to get care and stay continually in care. On a structural level, unfortunately, political climate has a large influence on the accessibility and availability of HIV care, as well as whether individuals feel more stigmatized, and on the poverty, as well as poverty being one of the biggest determiners of whether individuals can access HIV care. And so one potential tool to address some of these challenges is the use of patient portals. Patient portals are web-based tools that allow patients to access their medical records, communicate with healthcare providers, and manage their care. And the research has shown that engagement with patient portals has been linked to improved viral suppression rates, better retention and care, meaning that they're able to continuously go in for doctor's appointments, get their medication refilled, which is kind of my next point, increase medication adherence. And so the objectives of my research was to identify barriers and facilitators to portal use among youth living with HIV, as well as inform improvements in portal design and content. So shifting gears into the methodology, this was a secondary qualitative analysis of the eShine study. Interviews were conducted from May 2022 to March 2023, and participants were all youth living with HIV, both perinatally acquired and those who acquired it later on. And they included individuals ages 13 to 25. And they engaged in semi-structured, in-depth interviews over Zoom. As for the data analysis technique, we used the radar technique to analyze all the data, the interview data, and in order to further refine analytic output, such as the sub-themes, themes, codes, we used a visual mapping exercise conducted on the Miro platform. So as for the results, we identified several themes, and one overarching theme in terms of facilitators was that patient portals were seen to reduce the administrative burden and enhanced engagement in care. In terms of reducing the administrative burden, everything was confined to their patient portals, all in one app. So they were able to schedule appointments, get the prescribed medications, talk to their providers, all in one place, which simplified additional administrative barriers to making sure that they're continuously getting the care that they need. And secondly, there were a lot of health monitoring opportunities that were provided to youth that promoted reassurance, with one participant noting how I can always look back at my results and just settle my conscience. And then secondly, another overarching theme in terms of barriers was there was limited health literacy and interface design that constrained portal accessibility. Across a lot of the interviews, what we noticed was that there were significant issues with interpreting lab results. A lot of participants saw the numbers, but they couldn't really understand whether that was good or bad, which led to them messaging their provider. And in the long run, something like that could potentially add undue administrative burden onto healthcare providers. In terms of portal accessibility, a lot of participants described how there were a lot of features on the patient portals, but they didn't know how to get there or how to access it. And my last theme was that youth identified several opportunities to enhance engagement on patient portals, with the first one being they desired youth-friendly interface design, so a visual appearance that is much more engaging, as well as more educational games and content so that youth can use those games to learn more about conditions that are relevant to them. Similarly, they also described getting more prompts from patient portals, so promptings to take their medications on a timely basis, promptings to schedule their next appointment, promptings to get at-home testings. So much more holistic care also incorporated into patient portals. And similarly, integrating local healthcare resources into patient portals. So a lot of them also endorsed having mental health resources and sexual health resources, with one participant noting having at-home tests where they can find that locally in the patient portals. And so there were several key findings, with the first one in terms of facilitators being that patient portals, they did improve their accessibility to care as well as the convenience. Secondly, accessibility to labs, being able to look at their lab results, they promoted a lot of reassurance for a lot of AYA. In terms of barriers, unfortunately, there was a lot of difficulty interpreting lab results and issues with interpreting a lot of the language that was used throughout the patient portals. Several also noted that there were navigational challenges and limited awareness of all the portal features. And as for opportunities, youth identified the desire for more interactive educational tools and more clinical reminders. So reminders to take your medication, reminders to get STI tested, as well as an improved interface design that is useful and much more catered towards youth, and access to more mental and sexual health resources locally. There were several limitations of this research. The first one being that this was conducted as single academic medical centers, which can unfortunately limit the generalizability of the study to other various diverse medical contexts. Secondly, something unique to the study was that participants were relatively tech savvy, meaning that especially for those who had perinatally acquired HIV, they had continued engagement with the healthcare system in order to get the care that they needed from a young age. And lastly, data collection was done almost 3 years ago, and so portal features may have been updated in the last 3 years. And so I've kind of summarized what are the key takeaways that we found, with the first one being that there is a need for plain language explanations of lab results. And secondly, improving portal usability and feature visibility, making sure that youth are able to access all the various features given in a patient portal so that they're able to utilize that patient portal to its maximum benefit. And thirdly, incorporating a youth-centered design, which is sometimes very crucial to get them more engaged and using the app more. And lastly, expanding portals to support holistic care, so integrating resources related to mental health, sexual health, and others. And with that, I'd like to move to close this presentation. Thank you all so much for listening. I just wanted to say a special thank you to Dr. Jackman, Nancy, Elise, and all members of the AUDL project for their support and guidance, as well as all my PFRH colleagues, friends, staff. Thank you all so much.
Wonderful presentation, Hannah, and I see lots of claps, lots of cheers for you in the chat here. Thank you so much for sharing that presentation. I'll open up the floor, as Hannah said, for any questions from students about Hannah's work. Yeah, I see. Mary Alice's hand went down, so we'll go to the other hand. Ayushka, do you have a question you'd like to come off mute and ask?
Yeah, thank you so much, Hannah, for this great presentation. I work as an HIV counselor with Baltimore Youth, so a lot of what you shared was really resonant with what I've seen in my experience. I was just curious and wanted to ask you, what was the most surprising finding for you? And was also wondering if you could share a bit about your experience on this project.
Yeah. So I guess my most surprising finding was the limited health literacy aspect. I didn't know that a lot of it, and it makes sense now that I look back and think about it, but a lot of participants kind of noted how patients didn't really know how to interpret these lab results. And what they would do oftentimes is message their providers in order to get much more better clarification. And as for your second question, my experience with doing this master's essay presentation and finding and writing out the essay was amazing. I was able to work for the last 2 years with the AUDL project with Dr. Jackman. And so I was able to get really well acquainted with the team, and they're all super resourceful. So I was able to have a really smooth experience because I've been working with them for the last 2 years, so this just really fit right in with a lot of my research interests. But thank you, Ayushka, for your question.
Great, thank you. And I think you have another question from Dominic.
Yes. So, as someone who's also drawn to this topic, well, first off, it's a very great presentation, very informative. I really liked the results section when it had like the illustrative quotations and just seeing that like how they respond to the care and like their disparity in care. That was really like eye-opening just to see like how the patients were responding and how that could differ just to like normal patients on a day-to-day basis. But my question is, just someone who was also drawn to this topic, I just want to know like your perspective into getting into this type of like themes. So I just want to know like what drew you into this topic? Why did you present on it? And how has this like affected you throughout the years?
Yeah, thank you, Dominic, for your question. So what drew me into this topic was I've always had an interest in health informatics. Before I came to Hopkins, I was also working as a medical scribe. And so I used electronic health records very often to document doctors' encounters. And something that we see in most patient visits is a lot of people don't know how to use their patient portals. And so it adds undue time, or not undue, it adds additional time to these doctor's appointments because sometimes they do have to sit down and help them navigate towards using their patient portals. And what I've seen is that the people that use their patient portals the most are the ones who remain the most engaged and connected to care. And so a lot of this was kind of driven by my personal experiences, as well as just a research interest that, health informatics at the intersection of sexual health. It just really fit right in with what I really wanted to get to learn more about.
Great. And I think we have time for one last question from Aditi.
Thank you. Hi, Hannah. That was a really great presentation. Thank you so much. I'm a behavioral health provider, and for me, working with youth with HIV and experiencing stigma and a lot of even systemic and personal levels, do you have any feedback for providers or just for the industry at large? Any general suggestions that you might make to make this process more trauma informed and more inclusive for these youth?
That's a great question. Thank you, Aditi, for your question. I think the biggest thing that I've learned from this presentation and doing the research and working with the Auto Project is that we need to incorporate more youth voices because they're the ones on the front lines experiencing this. So making sure that we're incorporating their lived experiences into what we're doing, and letting that inform future development of future projects, updates to patient portals. I think that is so essential. Even if they are younger, I think their experiences and their voices are so valued, and I don't think that there is enough, unfortunately. So integrating them into everything that we do, I think is really, really essential.
Thank you. Thank you, Hannah, and thank you everyone for the great questions. I know there were a few in the chat that didn't quite get answered by folks during this session, so please feel free to follow up with those who reached out to you to make sure they get their questions about your important work answered. I'd just like to thank everybody for tuning in today, and a huge round of applause for our 4 presenters. You put in tremendous work to each of your master's essays, and it was really great to learn about your work and to applaud you in all of your efforts today during this session, and a really great session to kick off all of the master's essay presentations. So thank you. Thank you to Mary Alice for coordinating this session. And I hope everybody has a wonderful rest of the day. Congrats to all.